Hi, and welcome to our presentation. We're Josie Raftelis, Hannah Kavanaugh, and Brooke Waldrop. Today we're going to be discussing the growing public health crisis that is antibiotic resistance. This issue is affecting how we treat current and upcoming bacterial infections. Antibiotic resistance occurs when bacteria evolves and develops defenses against the antibiotics designed to kill them. This causes bacterial infections to be harder to treat, therefore affecting the illness's timeline and severity. According to the CDC, there are over 2.8 million cases of antimicrobial infections each year, resulting in over 35,000 deaths nationwide. We have explored possible alternatives for antibiotics such as vaccines, environmental changes, bacteriophages, probiotics, and antimicrobial proteins. If left untreated, the problem will only get worse. According to the World Health Organization, it can cause an increase in drug misuse, deaths, risky medical interventions, and economic spending. To address this, our evidence-based practice intervention aims to increase awareness of antibiotic resistance and its future implications, while promoting new alternatives for antibiotics. Our thesis is utilizing non-antibiotic medical treatments instead of antibiotic treatments will help reduce antibiotic resistance in patients with bacterial infection. This shift in treatment approach can help preserve the effectiveness of antibiotics for critical cases while still offering quality care. To guide and support our intervention, we searched on Google Scholar and JSTOR using terms like antibiotic resistance, alternative antibiotic therapies, and attitudes towards antibiotics. The database presented us with a multitude of articles, but finding ones within the last 5 to 7 years was particularly challenging. This just convinced us more on how important research in this topic is. The first article explores how patients understand antibiotic resistance and its future implications. 5 themes emerged: the misunderstanding of antibiotic resistance, antibiotics resistance is perceived as a future problem, low awareness of antibiotic resistance spread, low awareness that antibiotic resistance can change over time, and antibiotics viewed as necessary with little risks. The second article analyzes internal and external factors that are contributing to the rise of antibiotic resistance. For undeveloped countries, this is the lack of surveillance, poor quality, clinical misuse, and ease of availability. For developed countries, this is poor hospital regulation and in-use food-producing animals. For both countries, it's economic disincentives and regulatory barriers. The third article reveals the issue of antibiotic resistance by exploring and dissecting predictive models involving 1,655 E. coli strands. It uses accessory genes as predictors and population contributors to aid in early detection. The fourth article explains that rotavirus is a highly contagious virus that causes gastroenteritis. Although it does not require a prescription of antibiotics, the secondary infections caused by it do. Therefore, vaccination against rotavirus is a proposed strategy to reduce the incidence of these infections and therefore antibiotic use. The fifth article assesses the public health risks posed by antibiotic resistance in the natural environment. It explains the prevalence of antibiotic resistance from agriculture land and natural bodies of water. The sixth article explains how multiple factors, whether it's social, cultural, economic, or behavioral, can influence antibiotic resistance. It dives into Greek society to confirm these beliefs. The seventh and final article reveals antibiotic alternatives to combat bacterial infections. The theories include antimicrobial proteins, bacteriophages, probiotics, and plant-derived antimicrobials. These are all more specific and environmentally safe and less to cause resistance.
Antibiotics have long been the cornerstone of treating bacterial infections. However, the rise in resistant strains has made treatment increasingly difficult, turning antibiotic resistance into a major public health concern. To preserve antibiotic efficacy, research into alternative treatments is essential. Some promising alternatives include vaccines, environmental modifications, bacteriophages, probiotics, and antimicrobial proteins. Still, introducing these alternatives presents several barriers. These include fear of unfamiliar treatments, lack of understanding of their effectiveness, and public resistance to change. Healthcare providers and patients alike may be hesitant given the long-standing reliance on antibiotics. Many patients don't grasp the urgency of antibiotic resistance, often seeing it as a future problem. They may also view alternatives as unproven or experimental. To address these concerns, we propose educational initiatives, demonstration of clinical efficacy, and efforts to dispel common misconceptions. First, educational campaigns should target both healthcare professionals and patients. Providers need updated guidelines and training, while patients benefit from accessible information through clinics, pharmacies, and community outreach. Second, we must build trust by demonstrating the success of alternatives. Clinical trials and evidence from case studies, such as the rotavirus vaccine's role in reducing antibiotic prescriptions, help legitimize these approaches. Lastly, we need to address the misconceptions. Many still believe antibiotics are necessary for all infections. Clear visual tools like infographics, FAQs, and trusted messengers can help dispel these myths. By educating, demonstrating, and communicating clearly, we can reduce fear, improve understanding, and help pave the way for broader acceptance of non-antibiotic treatments. To move forward in combating antibiotic resistance, we propose a Plan, Do, Study, Act cycle centered around this thesis. Utilizing non-antibiotic medical treatments instead of antibiotic treatments will help reduce antibiotic resistance in patients with bacterial infections. Antibiotic resistance arises when bacteria evolve to survive treatments. This is fueled by overuse, misuse, weak regulations, and the use of antibiotics in agriculture. Patient understanding is also a critical barrier. Research shows that many individuals are unaware of how serious antibiotic resistance has become or the role they play in preventing it. That's why education and communication are such key parts of this proposal. Evidence supports the use of alternatives. For instance, vaccines like the rotavirus vaccine have reduced the number of antibiotic prescriptions by preventing secondary bacterial infections. Cutting-edge research even shows that resistance patterns can be predicted from bacterial genome sequences, opening the door for more personalized treatment. Bacteriophages are also gaining attention. These viruses target and destroy specific bacteria, offering a promising route that avoids the broad-spectrum effect of antibiotics, and therefore the resistance problem. Our PDSA cycle will evaluate both the effectiveness of non-antibiotic treatments and the success of an educational campaign aimed at raising awareness around antibiotic resistance. We have created a clear SMART goal for our PDSA. There will be a 10% increase in the use of non-antibiotic prescriptions for common infections by the end of 10 PDSA cycles. To measure this, we have identified 2 key outcome measures. The first one is to have a reduction in antibiotic prescriptions. With the help of public health agencies, we will annually measure the number of antibiotic prescriptions for infections that could be treated with alternatives by reviewing prescription records from healthcare providers and pharmacies. We would analyze it by comparing the number of prescriptions pre- and post-intervention. The second is to increase the use of non-antibiotic alternatives. With the help of healthcare providers and public health agencies, we will track how many non-antibiotic treatments were administered or recommended annually. To analyze, we would assess the percentage increase in the use of non-antibiotic alternatives. Stakeholders in this effort include healthcare providers responsible for prescribing treatments, pharmacists who offer guidance and information to patients whose understanding and participation are crucial, and lastly, public health agencies that will provide education materials and support in the implementation of the plan. To ensure every part of the plan is functioning, we will monitor the following process measures. First, we can track the number of educational sessions where healthcare professionals are trained on non-antibiotic treatments. More specifically, we would need to keep attendance logs and look at the total number of training sessions held and the number of people who attended each session. Training coordinators, HR personnel, or designated education staff could collect this data after each quarterly educational session. To analyze the results, we would examine the trends in attendance rates of the educational sessions and see whether or not the sessions meet a target for training. Second, we can track how many patients are prescribed or recommended non-antibiotic treatments versus antibiotics. This would include patient prescription data, patient demographics, conditions being treated, and specific treatments recommended. Physicians, pharmacists, health IT, or data analytic teams could gather data from the EHR systems quarterly. To analyze the results, we would compare the number of prescriptions or recommendations for antibiotics versus alternatives and see if there has been a shift. Lastly, we can use surveys or interviews to gauge patient understanding of antibiotic resistance and alternative treatments. Data would need to be collected annually by public health agencies or trained healthcare personnel. Specifically, qualitative and quantitative data on patients' knowledge, attitude, and perceptions regarding antibiotic resistance would be needed, and we would analyze the data by using a thematic analysis and statistical analysis. With tracking the process measures, balancing measures will help us understand the broader impacts of our interventions. First, we will measure if patient satisfaction increases or decreases with the shift to non-antibiotic therapies through surveys and interviews. Healthcare providers or public health agencies could collect this data annually, which would include quantitative data on patient satisfaction scores and qualitative data on patient experiences, preferences, and concerns. We would conduct a statistical analysis of survey data and thematic analysis of interview data to identify common themes and concerns. We would also measure whether or not the non-antibiotic therapies are equally clinically effective in treating infections compared to antibiotics. Healthcare providers and public health agencies could collect this data annually. The quantitative data will include clinical outcomes such as resolution of infection, as well as data on the types of infections treated and patient demographics. For analysis, there would be a statistical comparison of clinical outcomes between patients treated with non-antibiotic therapies and those treated with antibiotics. The intervention's utilization will be tracked by reviewing records of non-antibiotic treatments administered or recommended and the number of alternative therapies prescribed by providers. Legally, this information should be true and accurate since we are looking at documentation and treatment records and prescriptions from healthcare workers. Treatment records will be used to track the adoption rates of non-antibiotic treatments and assess the clinical effectiveness of these therapies. Pharmacies and healthcare providers will provide prescription records. EHR systems will be used to gather data on both patient prescriptions and recommendations for antibiotics and alternatives, as well as clinical outcomes and the types of infections treated. Training session records, or attendance logs, will be used to track the number of educational sessions and attendance rates. Lastly, surveys and interviews will be used to collect qualitative data on patient understanding of antibiotic resistance and alternative treatments. The data entry will be done manually into an electronic system, and the data will be collated, housed, and stored electronically in a protected database that is encrypted with an access key at rest. Data transmissions between healthcare providers, nurses, and the database would be encrypted using secure protocols such as transport layer security to protect the data as it moves across networks. We would also ensure that the database has regular and secure backups to safeguard against data loss. Finally, here's a breakdown of the estimated budget for this initiative. It would be around $1,200 per nurse for the meetings. Researcher payment for about 300 hours of work would be around $9,000. Alternative therapy price difference over 10 PDSA cycles would be around $30,000. And lastly, the database and or computer price for nurses would have a cost of around $50,000 to $100,000. This would lead to a total budget ranging from $90,200 to $140,200. While this is a considerable investment, the potential return, preserving the effectiveness of antibiotics for future generations, is invaluable.
In order to implement alternative therapies to prevent antibiotic-resistant infections, we need to have a longer timeline since according to Current Microbiology by Lojuska in 2021, the knowledge about effects of these therapies have limited studies and human trials. For our reduction of antibiotics plan, we're going to start with step 1. On day 1, all the participating hospitals will gather baseline information about how many antibiotics they are currently administering to their patients. For step 2, every month, nurses and providers will review how many antibiotics they are giving to their patients. For step 3, at every monthly check-in, they will evaluate the ways to decrease their antibiotic use. For step 4, every 6 months, nurses and providers will hold a meeting to review how many antibiotic-resistant infections they have. For step 5, every year, we're going to add everything together and see if we are prescribing less antibiotics, giving alternatives, and if there is a reduction in the antibiotic-resistant infections. Focusing on the antibiotic alternative plan, we will start with on step 1. On day 1, everyone, including nurses and providers, will have a meeting introducing the antimicrobials, bacteriocins, bacteriophages, and probiotics and how to implement them in their treatment plans. For step 2, on the first week, we'll measure how many antibiotic-resistant infections they've encountered and how many alternative therapies they've prescribed for the week. And then for step 3, every 2 weeks, they'll reevaluate how many antibiotic-resistant infections, antibiotics, and alternative therapies they had given throughout those 2 weeks. And then for step 4, evaluation to see if the overall use of antibiotic alternatives are increasing. We are going to be presenting our data in bar charts. We're going to use one about the presence of antibiotic resistance and one about the usage of alternative therapy use. To analyze these results, we will have everyone log both the number of patients with antibiotic-resistant infections and the number of alternative therapies they used each week, and then yearly and monthly, and average them all together. To analyze these data results, we will see if there is a correlation in the years of antibiotic-resistant infections decreasing due to alternative therapies increasing compared to using the antibiotics. After viewing the results of our study, we would act on our plans according to how much correlation was yielded from the previous trial. If the results of the study prove that there is a complete correlation between lowering antibiotic-resistant infections and increasing the use of alternative therapies, then all the participating hospitals would begin to implement alternative therapies as first or second-line therapies when it is implicated. If the results show only a 75% correlation, we will re-educate staff members on the importance of preventing antibiotic-resistant infections by using the various alternative therapies instead of the antibiotics. If there is less than a 50% of a correlation shown, then we will go in and reevaluate the therapies being used and to see if there is more research for different alternative therapies that we could implement. We would also go in and look if there are certain confounding factors that could be skewing our data. Then, once our changes are made, we would re-implement the new teaching methods of our new alternative therapies. After getting our results, we could then further stratify our study by targeting specific hospitals that have high antibiotic-resistant infections and hospitals that prescribe the most antibiotics. This way, these hospitals have the greatest yields in our data if our implementations are working. Once we get our results, we will want to spread our research to the National Institutes of Health and the National Science Foundation in order to try and get more grants for research and higher opportunities of getting our research published and spread to the general public. We would also reach out to newspapers like Science News and other medical journals in order to spread awareness towards our work and the benefits that come from using alternative therapies compared to antibiotics.